Good afternoon. So thank you for asking me to give this update on liver transplantation for cholangiocarcinoma. What I'd like to try and do over the next few minutes is just talk about the history and particularly focus on the poor outcomes and early recurrence that's been associated with liver transplantation. I'd like to emphasize that liver resection or bile duct resection is only possible in a minority of patients, and that when you do surgery, it's associated with somewhere between a 20 and 40% 5-year survival. And the problem is, and it's well recognized, that local recurrence is both common and is associated with a dismal outlook. For the surgeon, the problems are about leaving sufficient liver present to avoid complications such as small for size liver syndrome, which leads to recurrent infection and premature death after surgery. And the final aspect that's important for surgeons is that 10 to 20% of patients with cholangiocarcinoma have either sclerosing cholangitis or some other form of liver disease, which precludes successful surgical intervention. Now, the background here is really important because things are changing. Over the last 10 years, we've seen increasing organ donation within the UK, and I'll show you that there's potential for greater increases in this. We've seen changing indications for liver transplantation. The success of antiviral therapy for hepatitis B and C has had an impact on the number of patients coming through with end-stage liver disease due to these particular diseases. We're seeing an increase in non-alcoholic steatohepatitis as an indication, but most importantly has been that for hepatocellular carcinoma, where in our center, probably around 30% of patients are being transplanted for oncological reasons, and this is set to increase. So transplant surgery is becoming much more focused as an oncology specialty rather than purely just for treating end-stage liver disease. And I think this is also important in terms of how we start to look at patients with cholangiocarcinoma. And now, for the first time, we're seeing improvements in chemotherapy, the advent of effective radiotherapy, and an improvement in at least short to medium-term outcomes. And then for transplant surgeons, we have to get away from seeing pure survival as being the overriding reason to offer transplantation. So is 95% survival at 1 year better than 90%? Well, yes, for chronic liver disease, but not for cancer. And so there's this change coming as to what might represent optimal outcome after liver transplantation for cancer. This is data from the National Database for Organ Donation. And you can see here, over the past 10 years, there's been an increasing number of organ donors, which translates into, in the black line here, a lower waiting list for liver transplantation. If you can see here, following through from the number of patients dying each year through to actual donation and transplantation, you can see still for donation request, consented donors to actual donation, there's still the potential to increase organ donation and transplantation. So we've got a reduction in the number of patients potentially coming through with chronic liver disease, an increase in oncological referrals, and an increase in donation. So this means that we can focus much more on cholangiocarcinoma and liver transplantation. So I said the early experience for both intrahepatic and hilar cholangiocarcinoma was disappointing, with outcomes that were associated with less than 30% survival at 3 years. But over the last 5 years, we've had accumulating evidence that selected cases and series have a survival advantage for 2 groups. Those with perihilar cholangiocarcinoma with or without cirrhosis, and for intrahepatic cholangiocarcinoma on a background of chronic liver disease. And what I'll go through is the published data so far that starts to provide pointers as to patient selection. I won't say much about neoadjuvant chemoradiotherapy. I think that will be covered by other speakers. And I'll talk a little bit about the challenge of delivering treatment within a constricted time frame, and try and reflect on analysis of survival on an intention to treat basis due to the perceived high rate of dropout for patients selected for liver transplantation. I think it's important to say that that also applies to patients who are being treated for surgical resection. I'll go back to this paper published by Peter Neuhaus more than 20 years ago from Berlin. So they took the view that liver transplant with a more extended resection of both liver, pancreas, duodenum, and regional lymph nodes might provide for better survival. Of 15 patients, 14 had clear resection margins, so the surgeons were successful at apparently removing tumor, and without neoadjuvant therapy, this was associated with a 5-year actuarial survival of 40%. I think at that time, surgeons felt this was not good enough to offer liver transplantation for this indication. Now, subsequently, Omaha adopted a protocol of liver transplantation for perihilar cholangiocarcinoma that was quickly taken up by the Mayo and has now become referred to as the Mayo Protocol. And this was important in defining a patient group with perihilar cholangiocarcinoma, where there was a malignant appearing stricture with a definition of what might be a positive tumor, where the tumor was defined as unresectable in the setting, at least in the Mayo Protocol, within the setting of sclerosing cholangitis. For Omaha, it was just peripheral hilar cholangiocarcinoma. What was important is there was no attempt at resection or of percutaneous transperitoneal biopsy, lymph node negative, defined as unresectable anatomically, but without longitudinal limits for bile duct involvement, but restricting the radial tumor size to less than 3 centimeters. This was associated with radiation therapy, chemotherapy, and in the early series, brachytherapy with oral capecitabine until transplant. And they were using a staging laparotomy before transplant to exclude lymph node involvement. Their early experience showed of 19 patients enrolled, 12 were eligible for transplant, and about half of those were transplanted with a 1-year survival of 90% and a 5-year survival, actuarial survival of 76%. Tumor-free at 5 years, actuarial survival of 60%. They identified a number of risk factors: older, tumor grade, perineural involvement, and prolonged waiting time. Their subsequent experience has been expanded to 65 patients, 1-year survival of 90%, 5-year actuarial survival again of 76%. There's criticism of this study that only about half the patients had biopsy-proven cancer, and the definition and identification of positive tumor has been tightened since that time. An overview published subsequently of the US experience following a similar sort of protocol of 287 patients over quite a wide period of time showed a disease-free survival of 65% at 5 years, an intention to treat 5-year survival of 53%, with a dropout rate of just over 11%. What they showed was liver transplantation without neoadjuvant therapy was associated with higher and earlier recurrence rates. What's important to say from this Mayo Protocol is that there's a high morbidity at transplantation, primarily built around infection, but also associated with late vascular complications, hepatic artery thrombosis of around 20%, and portal vein complications in 1/5 of patients. Actually, you can get over these complications with a modification to the surgical approach, avoiding anastomoses within the immediate radiated area. So this is avoidable. They said success was down to their patient selection, neoadjuvant therapy, and timely access to transplantation. That is usually within 3 months of coming to the transplant list. And the Mayo are now transplanting between 10 and 20 patients a year. So that represents a reasonable number. Is it reproducible elsewhere? Well, the answer is yes. Dublin published their experience over a similar time period of 27 patients, getting 20 through to transplantation. They had a higher inpatient mortality, and I think that represents a learning curve for surgical implantation. Of the patients who survived to discharge, the 1 and 4 year survival was 94 and 61%. There were a significant number of patients who had recurrence, and there were 9 out of these patients who had disease-free survival at 37 months. So this is reproducible by other centers. A retrospective study of 21 European centers, none of which were in the UK, identified 147 patients, of whom 28 met the Mayo criteria. So many were outside of this, without chemoradiation. The majority had an R0, that is a clear resection, and liver transplantation only. And here they reported a 5-year survival of 59% with a median follow-up of just over 4 years. This was a paper published quite recently which attempted to compare liver resection versus transplantation for perihilar cholangiocarcinoma. 10 institutions, 300 patients, 234 attempted resections, and they excluded 43 with involved resection margins. 70 patients were involved in liver transplant protocols, of whom a small number had no transplant, and 5 had no positive histology. So in this comparison, they had curative intent in 191 resections and 41 liver transplants. Liver resection patients tended to be older, fewer, as you'd expect, had sclerosing cholangitis, and the survival was very different, both in terms of 3 years and at 5 years, with a clear statistical difference, even accounting for survival on an intention to treat basis and tumor size. So suggesting that liver transplantation seems to have a clear-cut place for the management of perihilar tumors. In another meta-analysis by Cambridge and colleagues of 20 studies with 400 and odd patients, they could demonstrate that there appeared to be a role for neoadjuvant chemoradiation in terms of survival at 1 year and 3 years. But it was at 5 years that there was real divergence between the two groups of patients, showing that the pooled recurrence at 5 years was much higher in the no neoadjuvant group. But also they showed that there was a degree of difference whether you had sclerosing cholangitis or not. So the summary from that meta-analysis was that liver transplantation had more R0 resections, 90 versus 70%. The perioperative mortality was higher, but I think this does represent a learning curve and could be performed with lower mortality. The dropout rates were present for both transplant and resection, and they were at least similar and maybe even higher for resection. For liver transplantation, you don't need drainage, you don't need liver manipulation, which is an important reason for dropout, and that neoadjuvant therapy preceding transplantation appeared to offer an advantage, and that the dramatic fall in survival between 3 and 5 years after resection seemed to suggest that transplantation was a clear and viable option for the longer term. So now I'm just going to turn briefly to liver transplantation for the treatment of early intrahepatic cholangiocarcinoma in patients with chronic liver disease. This came from a study from Spain of a retrospective cohort of a multi-center study looking at 29 patients with intrahepatic cholangiocarcinoma of smaller than 2 centimeters in size. They reported recurrence associated with larger tumors, either by volume or size, the presence of microvascular invasion, or for poorly differentiated tumors. In this highly selected retrospective group, the 5-year survival was 73% without recurrence, so pretty promising. A subsequent study from the same author looking at early intrahepatic cholangiocarcinoma of 81 patients this is on explant, so this is highly selected retrospective, looking at hepatocellular carcinoma, intrahepatic cholangiocarcinoma, and they could identify 5 years that the cumulative risk of recurrence for very early cholangiocarcinoma was low compared to advanced tumor, and even with actuarial survival for early intrahepatic cholangiocarcinoma, they had a 65% survival at 5 years. So promising data. Could it be applied to a wider group of patients? So this is French data, recently published, multi-center, confined to France, of 49 patients having liver transplant versus 26 who had resection. And you can see that tumor recurrence in this group of patients was lower with liver transplantation. The 5-year disease-free survival was higher. And actually in this group, again, although retrospective, it suggested that you could expand the tumor size and still see a low instance of recurrence as compared to liver resection. So in this study, they concluded the liver transplantation was protective for recurrence and that survival was comparable between intrahepatic cholangiocarcinoma and mixed tumors. So where are we now in the United Kingdom? Well, it's been accepted now in principle by the Liver Advisory Group and by the national group that 2 groups should be considered for transplantation. Early intrahepatic cholangiocarcinoma with chronic liver disease who are surgically unresectable. And the second group to be considered separately are those with perihilar cholangiocarcinoma. And there's a group now to define patient selection and how to do it. The characteristics I won't go into again, but they're very much along the lines published by the international groups of small tumors without extrahepatic disease. Exclusion criteria are for larger tumors at the moment, but I think there is a debate to be had on tumors between 2 and 5 centimeters in size based on the French data, which I think is quite compelling. In terms of the perihilar tumors, well, the tumor selection for those tumors of less than 3 centimeters diameter, lymph node negative, defining unresectable. So I think now transplantation is coming for intrahepatic cholangiocarcinoma on a background of cirrhosis. The challenge is to identify the patients and get them treated within what is quite a tight time frame. Transplantation for perihilar cholangiocarcinoma, I think we can make a case both with and without cirrhosis. The problem, I think, is for surgeons defining unresectable. Each surgeon has their own view of this. But identifying patients earlier with close surveillance programs, particularly for chronic liver disease and sclerosing cholangitis. Having a national protocol with a schedule of treatment for neoadjuvant therapy, both for radiation and chemotherapy, should allow us to take things forwards. Thank you very much.